So Valeed, recently had quite a lot of news articles around the sugar tax, and really my understanding is that the sugar tax was introduced to really push through some behaviour changes, eventually then reducing the sugar that everyone is consuming and the health aspects of that. It's been in place for about 5 years now. The question is, from what we see in clinic, do you feel like it's made a difference, and do you think there's enough evidence to show that it should continue?
I mean, I think evidence is probably the key comment here, isn't it? So I feel like we overcomplicate these things sometimes. If we thought of it very simplistically, we've made things that are bad for you more expensive, so that hopefully you'll have less of them. That's the simple analogy here, isn't it? And so the question is, have people had less of it? I'm not sure that that's the case. So we know that some companies have just paid more tax to keep their product high in sugar, high in glucose. A really good example, there's a particular soft drink, a company, I don't want to be naming companies, but there's a particular one that is now known to be the only one on the market that still has full sugar because they're happy to pay the tax. Yeah. So if you really want a hit, you just buy that one. Yeah. And you pay a bit more for it. I don't think paying a bit more gets you seen any quicker in A&E. It's not like paying that sugar tax gets you any better access to healthcare.
That's true.
And we know that from a country morbidity perspective, we know BMI is still increasing. We know obesity rates are still increasing. We know the rates of diabetes is still increasing. So it seems like there hasn't been a significant impact, but you'd need some sort of national assessment in terms of, this is how many people were buying a drink that had high sugar in it. This is what the statistic looks like today. This is the percentage improvement. And my assumption is if people want to eat unhealthily and they can't afford a sugary drink, they'll go buy something else that is sugary. Yeah. That's my assumption. But I would hope there was some evidence that we could rely on, and I've not really seen anything.
Yeah. I always wonder about these initiatives about increased cost, increased tax coming in, but where's that money being spent? Because you just alluded to the fact, well, actually we're seeing increased numbers of obesity, the associated illnesses with that, diabetes, CKD, etc., and they're putting an added pressure on A&E, on primary care. The question is really then, if you were then put in a position of, well, actually, let's scrap the tax, let's look at improving the health of our population to reduce the demand, what would you do? How would you approach it?
I mean, let's say you had a focused initiative.
Yeah.
Because I think the reality is, if you've increased the tax on something, more money's been made. And the question is, was the aim to make more money, or was it to improve health outcomes? We have to assume it was to improve health outcomes. Let's say that money was ring-fenced for a particular activity, right? So if we said, in every area there will be a sugar tax, and that sugar tax will go into making gym membership free, or it will go into providing wellness coaches, or it will go into free nutritional support or free dietetic support. We know the access to nutritional services, dietitian services is shocking nationally. That would make sense, because then you would say, well, we've collected this pot of money in this area, and in this area there's loads of money being spent on this issue, so we're going to focus nutritional support on this area. And if there was an area that didn't spend lots of money on sugary drinks, in principle they need it less. So you would directly correlate the amount of support to the amount of tax raised in that area in a way that's meaningful. I mean, ultimately the question is, this feels very normal for what we do in the NHS, right? We normally react rather than prevent. So I would argue, if you were to look at countries where everybody isn't having sugary drinks, what are they doing? It's about balanced eating. It's about school education. It's about making things more fundamental. You can still go to a primary school and see loads of horrible things in the cafeteria. Making it more expensive for them to buy a drink from the vending machine probably isn't the answer. You probably want to do something from a fundamental education level. And I feel like we're in this constant cycle of reacting and not preventing.
Yeah.
And I don't think we have any evidence on whether the reaction has had any benefit.
Yeah. And I'm just having put my GP hat on here, is there's so many things that in a consultation you have to get through. And putting in the education, unfortunately, sometimes comes last. I mean, we only a couple of weeks ago had a conversation about how many things can you fill into a 10-minute consultation whilst also following an evidence-based management plan for the condition that's in front of you. So questions, who should the ultimate responsibility lie on? to educate, to follow that, and to have to sustain change?
So this is, we're talking about capacity problems here, right? Because I think the easy answer is let the GP do everything. And I think what you then end up with is no appointments with the GP. That's the reality of the situation you end up in. So we know there are conditions where diet makes a massive impact. So we know when you look at menopause, when you look at irritable bowel syndrome, when you look at migraine, when you look at diabetes, these are all conditions in which diet plays a major role. And we don't do that well, right? So these are conditions that where we have to manage a patient and their expectations, and we don't give them good diet advice because we don't have the time. And realistically, what does that look like? You know, are we talking about a GP having a single or double consultation with a patient to go through a diet sheet in detail? Is that what we're describing? Because that sounds like a massive inefficient use of resources.
100%, because half of it will not even be retained. That's the difficulty. It's probably a better approach to have it on multiple avenues and have it on bite-sized information. I mean, I know myself, I remember things much better when I get a little bit of information one week and then the next thing another week.
I tell you what I think works really well, but it requires a lot of time investment, is when I've had really, really complex diabetic patients, or when I've had somebody that has a migraine and they've tried everything and you're sort of going back to basics, and you've needed like 30 minutes with that patient and you've had to go through and map things out individually, right? I've had to pull up a glycemic index chart and I've had to say, right, green, amber, red. Green is good, amber's okay, red is bad. And these are all the things in red that you're currently having, and let's move them over to green. And that's really helpful for a single consultation. But that's 3 people I did not consult when I've spent half an hour doing that, right? To make a tangible impact on one person's diet. And to me, this is a dietitian or nutritionist area. We have people that make a living doing this. And I can't help but feel like if we just had the ability to say, right, you've got significant issues with your diet, I want you to go speak to a specialist that can talk you through this. And they're going to see you within a reasonable time frame while you're still passionate about it, because I've given you some energy today. But if you have to wait 6 months to go see a dietitian, I think you're going to carry on doing what you're doing and you're probably not going to see the value in it. And then the dietitian doesn't use your system, doesn't have access to your health records, so they don't.
We're getting into a whole different category.
It's very, very fragmented, isn't it?
Yeah. So I guess the short way around it is really dietitians and utilizing a system that's a bit more cohesive. That's probably the best way to describe it.
Yeah, if we're talking about healthcare, we're not talking about doctors, we're talking about healthcare, right? So if we're talking about sugar and diet and food, who are the experts in sugar, diet, and food? It's going to be the people that specialize in nutrition. And if you were to ask the average GP, how do you access a dietitian? I think the answer would be you send a referral and they might see the patient. And it's not because they don't want to. I'm sure they're under-resourced, understaffed, underfunded. And, out of interest, you can get dietitians as part of a PCN. How many PCNs have you seen that use a dietitian?
To be honest, from all the clients that I speak to, it's not one of the roles that is in demand. We're looking at more ACPs, pharmacists that are being utilized. And yes, to be honest, if I speak to most PCNs, they might not even be aware. That dietitians can be.
I feel like in America or in places where they practice wellness and holistic medicine, there's a large emphasis on nutritional support and dietetic support, and they definitely have a space in the private market, but we definitely don't seem to be making use of them in the NHS.
An interesting point you mentioned, and I think it might go on a tangent, but we might as well go through it, is the healthcare system, the electronic health record. I know from our different roles, we get involved in technology quite a bit, but I know that you've got quite a lot of opinions around how, even with the recent budget, the millions that have been added to improving or increasing the amount of tech that's been used. The budget's there, but I know you've got your own opinions around how that should be used, or whether whether even money is the solution here.
I mean, look, I'm speaking from a very biased perspective here, right? Because I'm involved in the creation of tech, and I find that the NHS struggles with a couple of things, right? So one is it never seems to run out of the idea of having a pilot. Right. And I can't remember if it was Jim Mackey or someone that leads the NHS that said, the NHS has more pilots than the RAF. Like, it's just every month there's a new pilot happening somewhere that doesn't turn into anything. And the other thing is, there's no shortage of tech. There's no shortage of technology that is being created, which we cannot use, right? So it's so frustrating. So let's talk from an infrastructure perspective.
I think it'd be quite helpful to explain, because some of our listeners might not be in this space, to understand, like, well, how can there be a situation where there's so much tech, and how does that actually get then implemented?
So
what are the barriers there?
So there's lots of segments to this conversation. So let's talk from the very beginning. So you've got an EPR. So you've got EMIS, you've got System 1, and I've got newer systems on the market. These systems have to allow your technology to talk to the system, right? So it's not guaranteed, it's not given. The NHS doesn't make them give you permission, right? So they're private providers, and you can make the best piece of software to manage a migraine in the world, and this system can just say, no, thank you, right? We don't want your software to talk to our system. And I think, let's say the only thing the NHS did was fix that. That would be good use of money spent. Because we have so much technology that can't talk to the system, which means it can't use patients' data. So what you end up with is a clunky dashboard outside of the system that you probably need a second screen to access, which you then would probably have to either manually input data into, or you'd have to download data from this system to then put it. And now you've got technological barriers. Because now all the stuff I'm now describing, most people in healthcare wouldn't be comfortable doing, or they're going to feel like it's going to increase the length of the consultation. So then they're not going to use it.
Further adding to the capacity issues, isn't it?
So these are integration issues. So I think if you had a fix for this, first of all, that would be the first, that would be the first solution. The second one would be when somebody creates technology, the NHS is immature in assessing technology. Practically, not theoretically. So theoretically, it's got its standards, right? It talks about compliance frameworks. It talks about minimum standards of assessment. What they don't then tell you is most ICBs have a 1 year plus waiting list of approving a piece of technology, right? Because the panel that approves it is about 2 people. It's about 2 people long, and they're either on leave or off sick or got a lot of work to do. So your piece of technology is just sat there, and you email every 6 weeks for an update, and you just get told we'll get to it eventually. When that assessment is then done, it's not done from a perspective of, will this help someone's problem and can we get this enabled? It's almost a case of, here's a 25-piece checklist. Which one of these was not ticked? This one wasn't ticked. It's a rejection. Start again. So it's a very computer says no type approach. So when we've had to push tech in our practice, we've actually had to independently get a clinical safety officer. We've independently had to get a DPO. And we've had to almost create our own case to justify why we're using it. And what the ICB is very good at is then coming and saying, why are you doing this? Why haven't you put it through our team? Because we didn't want to wait 2 years. Is the reality of it. And because we've got the issue in the meanwhile. So these are some of the practical issues with technology implementation. You know, I tell you what I think is the solution. I think if the NHS just did what every other country did and had a framework, one framework, right, that people got onto, and this team made the assessment on this framework, and they said this software meets the criteria of what is deemed safe and what is deemed useful. And now it's been approved for national use. So now you can roll this out anywhere in the country. It doesn't need to go through an independent vetting process again. It's had its safety check. Because currently you do that for one ICB, you would then have to go do it again at another ICB. And it's a 2-year process everywhere. So unless you've got friends in the ICB that are going to push it along,
you're waiting for.
Yeah, you're going to be waiting a long time. So I think there's more fundamental issues. So I would hope the money for tech, if the money for tech didn't create a single piece of technology and just made the adoption, procurement and assessment of software work, that would be money well spent.
Yeah. Awesome.
So with regards to waiting lists, there's several things to consider. So on one hand, you've got, because we from the ICB get given a list, right? And they say to us, these are your highest rates of referrals. And can you see what you can do to reduce these referrals? So the ICB's already, they know this is an issue. So I'll give you an example of ours at my practice, right? So we had a high number of dermatology, gynecology and ENT. I think these were our top 3 referred specialties, which is really interesting because we have a dermatology expert in-house and we have like a women's health expert in-house. So I was like, why on earth are we like referring so many of these cases? Because we've got specialists in the building. So we did like a sample exercise where we took about 100 referrals from every category and analyzed them. It was really interesting is when I personally went through the referrals that were made, and something like 65 to 70% of the referrals that I saw didn't yet need a referral.
Okay.
Right. And that's just me having a look without even like delving into them in any great detail. I was like, this did not need a referral. This did not need a referral. Or at least on paper, it didn't look like they needed a referral. So I'll give you an example. Yeah. So I looked at a gynecology referral. It was for a possible endometriosis case where they'd only tried the combined contraceptive pill and nothing else. And there was no mention of, I've offered Mirena, it's been rejected, I've offered this, I've not tried the progesterone-only pill. Like anything else that the guideline recommends was not referenced. Yeah. So either it had happened and just wasn't referenced, or it hadn't happened. And it might have not happened because the patient wasn't willing, which is fine. But that needs to be documented. Yeah. Because what's really interesting is when you audit the referrals, you understand where secondary care's frustration comes from. Because they would look at that and they would say, well, you've not done anything. Yeah. Why have you sent this case to me?
They'll send a response back saying, try A, B, C, and D.
Yeah, and then it'll look like it's been rejected. Yeah. So if the stuff hasn't been done, then do it first. Yeah. So there's an element of trying to make sure we've gone through what we should have gone through in primary care. We definitely aren't doing as well as we could be doing. That's number one. Then you've got an element of, if you have done it, document it so that your referral's not going to get rejected or inappropriately triaged to routine. Because if they feel something is urgent, then they will escalate it. But you have to give that information to facilitate it. You've then got what I would class as barriers that force you to referring. And these are really, really frustrating. And I'm trying to work on these in my ICB at the moment, where there are conditions, where there are treatments that I know the patient needs.
But you can't initiate?
I can't initiate the treatments, right? Yeah. So it literally says send advice and guidance or refer to specialist. And I'm like, if this was a different condition, I can start this same drug. Yeah. I clearly know how to use this medication, but my formulary says specialist initiation. So I have to send advice and guidance. And then the person I send the advice and guidance to says, I can't give you advice on this. Refer the patient to me. So then I refer the patient to them and then they wait a year to be seen to then get started on the drug that I could have started.
And what you don't understand from a patient journey point of view, the symptoms aren't adequately controlled. They will still seek out healthcare professionals. They will still go call NHS 111. They will still go to your pharmacy. They will still go to A&E. And that then causes a lot of disruption. That's what you see with patients being quite frustrated, understandably.
So I don't want to blame organizations here, but if you look at this from a lack of proactiveness perspective, so let's take the new heart failure guidance, right? So the new heart failure guidance is very, very clear on a 4-pillar approach, which essentially says, don't just give one treatment and take it to full dose and get them started on all 4 of them, because these are the 4 medications that make a long-term impact on someone's journey with heart failure. We know that when you don't optimize heart failure, it worsens. They end up in A&E. They die sooner. We know heart failure has a prognosis similar to some cancers. Right. So, for all intents and purposes, a lot of heart failure is palliative, right? As in that there's no active treatment that's going to reverse it and you're just trying to control symptoms. Now, that being said, in my ICB, 50% of the medication I can't initiate for this condition. So there's very clear guidance that says start with an ACE inhibitor. And if not, don't move to an ARB, go straight to an ARNI. But an ARNI can't be initiated by me. SGLT2s I can't initiate either. That's half the treatment options. Yeah. So if I can't start that treatment and a person isn't happy to give me the writing go ahead on paper to say initiate it, then I can only refer the patient. So if I was to refer that patient, that's 6 months or 12 months of lack of treatment and lack of optimization that person has. So they are statistically more likely to decompensate and end up in A&E. Correct? Yeah. And I can't wrap my head around this. I can't wrap my head around the fact that we have a clear guidance, we have a national standard, we have an international precedent. We would have specialists in the hospital saying, this is treatment suitable to start. And for whatever reason, the commissioning boards just don't approve it.
Mm.
Or they never get to it. It might be on their agenda, but maybe they're so busy dealing with A&E waiting lists or referral backlogs or something else that this doesn't get addressed. And even so I've taken this to my ICB and I've said, my recommendation is this. I think we should start these medications in primary care in the following way. The amount of gymnastics I've then had to do afterwards, right? I kid you not, like I've had to go find a cardiologist that specializes in heart failure to have a chat with them on my own time. I've then had to put an application, which the cardiologist supports, to then write to the medicines optimization team at the ICB for them to then review at their scheduled meeting whenever it is. And this isn't my role.
No.
I'm trying to initiate a treatment for the patient. And I've literally spent the last month and a half finding cardiologists that are willing to speak to me. And then I found one who's willing to have a chat with me and was almost like, why are we having this chat? And I said, well, I want to do this and that. And then just do it. Yeah. So they just said to me, just start the medication. And I said, that's easy for you to say, right? Yeah. I'm the one that's going to get the email from the ICB saying, why
have you done this?
Why have you initiated this treatment? And, you've breached the formulary rules. And then I'm going to get a slap on the wrist. And nobody wants to be in the ICB's bad books, right? But my point is, let's say you're overwhelmed and let's say you're stretched. When people come to you with a solution and they come to you with an expert and they come to you with guidance, just make it easy for them. Yeah. Does it need to be this difficult? And maybe that's a bit idealistic because I'm sure there's lots of red tape, but I think these are the kind of things, like, just to be very candid with you, how likely am I to do this again?
So I was about to mention this. I was like, people listening here, there might be GP partners, there might be salary GPs, practice managers listening, and we're like, okay, cool. Valeed, you seem to organize your time quite well and go through all these places. But practically speaking, this is not something that you would even recommend everyone doing because everyone would be.
I mean, I don't think it's a GP's job to convince people to let them treat patients.
It shouldn't be.
I don't think that's what anybody signed up to do.
I'm just because I want to make sure. Well, ideally, I'd like everyone to have a bit of a take-home message or a bit of a practical approach to it. So you're talking about one aspect of following the guidelines, and then guideline says speak to specialist, yeah? But then also at the beginning, you were talking about reviewing referrals and people not really following the guidelines. There can be an argument made, and I'm just being devil's advocate here, that it's all fair and good saying that the guideline, you can optimize it, but you've got evidence in your own practice, for example, that people aren't even following the full guidelines. Yeah,
correct.
So practically speaking, that may be something to start. And what would be really helpful is when you identify this issue, how did you then actually address that in your own practice where you have got a bit more control compared to going to the ICB, going to a cardiologist, going externally?
So we took the approach of let's identify themes for why these referrals were getting sent, essentially. And we were expecting a lot of it to be patient demanded, but it wasn't. A lot of the time it was probably clinician uncertainty or probably a clinician feeling like they're helping the person. Right. So the first thing we did is we pulled some of the clinicians and we said, why did you do this referral? You're not wrong. You're not in trouble. Just explain it to me. Oh, well, I thought maybe I've missed something. Okay. What do you think the patient thought when you did the referral? They would assume that either you don't know what you're doing or that they need a specialist input. And how long is that specialist input going to take? And what do you think is going to happen to their anxiety in the meanwhile? Yeah. Do you see what I mean? Yeah. So it was approaching it from that perspective, but also what we did, and this might not seem very productive, is we just started intercepting the referrals. Okay. So we just said, partner to vet referrals before they get sent. So essentially, the referrals land at us, we ensure they're appropriate, and we were just like, no, do ABC and send back. And it sort of forces a change in behavior. What was really interesting, my secretaries knew when the referrals would get rejected.
All right.
Right. So that's really interesting, isn't it? So when we spoke to the secretaries, they said, yeah, so this person always sends a referral here and it's always to the wrong place. I'm like, oh, why don't you tell them? Why don't you feed that back? Oh, no, but they're a doctor. Do you see what I mean? So there's a little bit of like staff encouragement, facilitation. And I said, why are you sending this referral when you know it's wrong? You've been doing this job for 20 years. You know exactly what should be happening here. Feed it back. You've got our permission. In fact, no, I insist. I insist you feed it back with rationale, right? So that people can learn and stop making these mistakes. And if somebody makes the same mistake 3, 4, 5 times after you've told them, then tell us so we can have a conversation with them. And that's fairly significantly reduced our referrals.
So just to pick up a couple of themes, because I know we started off with massive waiting lists, decreasing referrals. So there's an internal process of vetting a referral in the first place to reduce the number, then also essentially increase patient satisfaction and patient journey. And there's an external process to empower the staff to be able to utilize all evidence-based treatment. Am I saying that right?
Yeah. And I think what we're talking about here is very practice level.
Yeah.
If you're looking at a more systems level, then you probably want to, because the ICB covers a very large patch and a practice is just one practice in that ICB, right? So you've got a cluster, which is then your PCN, and now you've got to talk about neighborhood models, which is obviously going to be even more broad. The thing to understand here is that your PCN is unlikely to make any significant impact on referrals, because the PCN DES is almost proactive cardiovascular prevention. It's not designed to set up a specialist clinic, which would replace a secondary care service. Let's say you've got a PCN that has a diabetic clinic. Potentially, you could argue that more diabetic patients are managed in that clinic and therefore they don't need referral onto the specialist. But in most practices, I would assume they're not making referrals to a diabetic clinic unless insulin is required, because most practices probably have the ability to manage a lot of this in-house, and a lot of practices manage insulin in-house. So with neighborhoods, the question is, what is the purpose going to be? Because if you're going to do, there's this whole talk about prevention, right? There's this whole talk about prevention in the community. Prevention takes a long time to kick in. So if you wanted to prevent a condition today, that person doesn't know they have a problem. They haven't suffered the consequence of it yet. So that's not going to do anything to your referrals, really, because your referrals are the problems from today. So what I'm concerned about, and this is just from what I see in the NHS, is this whole prevention chat is going to disappear, and your neighborhoods are going to become another reactive intermediary model. And so what I can fully expect to happen is, rather than let's do preventative health for people that are going to start going through the menopause, it'll just become a menopause referral clinic to reduce the gynecology waiting list. This is the normal trajectory of what we see.
But there's potential of that waiting list increasing.
Yeah, so all that happens is, right, so what we're really good at in the NHS is we're really good at bringing a waiting list down and we just throw it somewhere else, and then you have a waiting list there. So we're really good at shifting work. We don't ever seem to fix the work. We just seem to shift it. So fixing it requires prevention. If we allow prevention to happen, right? Like, I'll give you a really good example of this. We have high blood pressure as something we treat. We have diabetes as something we treat. How many conditions do we have where it's the step before that condition develops?
I think I know where this conversation is going to be going, because we were talking about, just on a train journey, about precursor illnesses.
Yeah.
And I'm presuming here, now I'm going to read your mind, we're going to be talking about COPD.
Yes. So before we get to COPD, right, let's address pre-diabetes.
Yeah.
So pre-diabetes is an established condition, and we know that when you make meaningful intervention, people reduce the risk of becoming diabetic, or it slows that risk down. It's the only precondition in the country that we manage in primary care. But the vast majority of conditions have some form of precursor illness.
Yeah.
And if we're doing real preventative medicine in primary care, that's where our focus should be. And the conversation we were having was around pre-COPD and how there's lots of international data about it. Because we know that most people with COPD are diagnosed many years into their illness, where lots of years of irreversible damage has already happened. And actually, pre-COPD, there's a degree of reversibility. A lot of the damage isn't fixed. So you're going to buy that person decades of life expectancy. You're going to reduce their amount of A&E attendances. You're going to reduce their need for home oxygen, reduce their need to be in a care home. These conversations aren't happening. Do you see what I mean? Like, nowhere. Like, I'm involved in some of this pathway creation, and I'm speaking to professors in respiratory for how we could set something up in primary care. But unless you're talking about a COPD patient and how to stop them ending up in A&E, unless that's the conversation you're having, it doesn't get addressed.
And there's a similar picture with CKD. There's enough evidence to show that actually measuring urine ACRs is a good marker, and in showing how it develops into mortality, really, with CKD. And how often do we see a GFR? We don't really bother with it until it's actually less than 60, which is almost half of the nephron's lost.
Yeah, dude, I don't need converting.
Yeah,
on CKD,
I know. But many people are listening, isn't it? We might get a million viewership here. So
I'll give a quick stat, right? So I have to put my coffee down for this. So
it's getting serious now.
So CKD is like my biggest bugbear, right? Yeah. Because it was taken out of QOF, so we're no longer funded for it in primary care. We know that urine ACR is an independent risk factor for cardiovascular death. We know our national numbers for ACR testing were in the high 80%. And we know in 2014 it was removed from QOF and it dropped to 40%. So we know that when you take these things out of QOF and you de-incentivize primary care,
impact.
They don't then happen. So we have lots of people that are undiagnosed, untreated as a result. And we know the evidence is so clear that if you were to start appropriate therapy in the early part of someone's CKD journey, you extend the time for them to need dialysis or renal replacement therapy by up to 20 plus years, right? And that's so important when you look at how much bankruptcy the ICBs are facing and how much of it is our renal replacement therapy. They don't have dialysis beds. They don't have dialysis units. We still don't have a CKD program. We still don't have a proactive method. And the thing that's nuts about this is you need a blood test, a urine test, and then starting a tablet.
Yeah.
Like, this is not surgery. This is not MRI, CT scanning. This is not specialist hospital. This is barn door, basic primary care stuff. And the amount of money you'd save the NHS in the long term and the amount of waiting lists you would reduce, right? If we're talking about nephrology waiting lists for kidney care, well, if you had less people developing advanced CKD, they wouldn't need to go see a nephrologist, right? You'd just be managing them in primary care. So there's... the thing that really bothers me is that the way to do this is actually written, it's established, and internationally it's accepted. The treatments are cheap, effective, and easy to do. And the data on how much benefit they bring is also there. And still nothing. I really, really struggle.
Oh, yeah. I can tell that was really woke you up this morning, isn't it?
It really, really, really winds me up.
Currently, there's quite a patchy or fragmented approach to prevention. We've obviously outlined a couple of different avenues here. Now, what would be really good is just focus on how we'd have a more cohesive approach.
I think there's a couple of things here. The first is we keep focusing on disease specifically. And I think one of the issues we have is it can feel like the amount of demands are never ending in primary care. So these two things, like pre-COPD, CKD, and things I'm really passionate about, these equivalent things will exist in menopause. They will exist in migraine. They will exist in lots and lots of other areas, and everybody will champion the things that they're passionate about. So if you had 10 of us that all had a different interest, there'll be somebody that has this exact view on osteoarthritis and knee health and joint health, and they'll have a whole thing that should be done for that. And the reality is the system as it is can't facilitate this, right? But one of the reasons it can't, but I guess what I'm asking for is the recognition that we should be doing it and the permission to do it. And then the financial incentive and funding to allow it to happen. So that's number one. The capacity and access thing is a whole separate issue. So the reality is you look at primary care currently, and by primary care I mean GP surgeries, and most people are offering less appointments than the patients are requesting. So you've got a mismatch. Asking that environment to do anything above and beyond is just not going to land well, right? That's common sense. But my fundamental question is, are we operating in an effective way? If we're not doing what the government wants us to do, what the patients want us to do, is that because they're all wrong, or is that because we're not operating well? Or is it a bit of both? And the reality is it's usually not just one thing. So at my practice, as an example, we just did a full bird's eye view of the whole thing. And we said, right, look, well, let's have a look at how many patients we're seeing, how many are asking for an appointment, what are they asking for an appointment for, what's the appropriateness of these requests, and where do we balance a request versus appropriateness? Because we are a state-funded service. Is the highest priority customer service? Is it patient experience? Is that what we're here to do? Because this isn't a private market, this is state-funded service. That still means people are entitled to a positive experience, but people's expectations can be ridiculous. In the age of social media and Amazon Prime, everybody wants everything yesterday, and usually it's not warranted. So there's something to balance against requests, expectations, and medical need. So we said, well, let's us make the objective assessment in terms of what's required. And what's really interesting about that is we've since then managed to give 200 consultations a month to the pharmacy, right, for acute care. What do you think that's done for our capacity?
Massively.
Do you know what I mean? That's on average 10 acute consultations every day that's been freed up across the practice, just in that. We've then sent about 50, 60 consultations for contraception to the chemist, lots of other things as well. So the nurse's time was freed up. So we immediately created capacity just by redirecting some demand. So that's number one. Then there's the question of the demand that's coming in, is it appropriate? So we had a lot of demand that was coming in because their chronic condition was not managed well, right? So what was happening was somebody might have not come in for their diabetic review, or their diabetic review might have not been followed up, or it might have not been done well. So what they're now coming to us with is a high blood sugar. But if that diabetic review was done well, they wouldn't be coming to us with the high blood sugar. Do you see what I mean? Like if we effectively delivered prevention. So then the second part was, right, let's get better at the prevention. Let's do this to a better level. The third thing was then patient engagement. So patients were saying to us, you call us in multiple times a year. You're now asking me to come in for this. I was in 2 weeks ago for a blood test.
Why are you calling again?
Why are you calling me?
Why do I have to take time off work?
Yeah.
And reschedule?
Or, and then what you find is you've got less, what I call emotional runway with patients, right? They're less forgiving of a mistake when they feel like you're wasting their time. So, for example, they come in for a blood test. You then bring them in 2 weeks later for a smear. But then on the day of the smear, your nurse is sick. And now they need to have their appointment cancelled. And they're like, well, hang on. I came in 2 weeks ago. You didn't finish everything then. You then rebooked me in. I took the morning off from work and now you've cancelled my appointment. Well, I'm here. So I need the smear to be done. But you can't magic a nurse out of thin air, right? So and then that person's really, really unhappy. So when they get your message in 2 weeks down the line to do a carbon switch inhaler from the ICB's request, and you message them, how do you think that lands? You see what I mean?
That's going to get straight deleted.
Yeah, so they don't engage with your messages then. So what we said is, right, let's stop getting these people to come in multiple times, right? Let's do the hard bit, which is assess the record before we invite them, and let's decide what needs to happen when they come in, right? Then let's decide how long would we need to deal with that person's volume of issues so everything can be addressed on that one occasion. So they only come in once. Everything is done. That person is going to feel like they got a fantastic service. Number one, they're going to be happy. Number two, they've had to take less time off from work. And number three, that person has less likelihood to deteriorate or have something go wrong. Because what we don't talk about is when we don't make this easy for patients and then they don't come in for their smear, that's a potential cervical cancer you've missed. That's the reality of it, right? So we fixed the way we did our recall and assessment. And then we had the same process for the chronic disease. So we said, let's now assess all of these conditions in unison. So they're coming in for their preventative care on one occasion. Let's train the staff up to the right scenario. And the reason I'm talking about this is the outcome, right? So the outcome is that we started the financial year in April, and by November we had completed our QOF.
That's amazing.
So, we'd completely finished our chronic disease processes. And obviously there's a bit of capacity for stragglers and new patients that join the practice. But it then allowed us over winter now to have capacity to deal with winter pressure. Because trying to get an 85-year-old who has a birthday in December to come into the practice in December to have a COPD review while it's snowing and wet is probably not going to land very well.
No.
But getting that person to come in for their review in June and then optimizing them so that they don't have an exacerbation in winter is where our effort should be. And we now have capacity over winter to deal with that patient. And I think this is never going to be what the NHS tells us to do, but this infrastructure correcting is what is required in primary care. We have a 50-year history of why we do it the way we do it, but we do more for conditions today. 50 years ago, we didn't do the 10 things for diabetes we do today, right? So let's redesign the way we deliver healthcare because it's been a long time. and there's a lot more to take into account. We didn't have smear screening programs at one point. Now we do. We didn't have to do pheno testing for asthma patients. Now we do. So we need a redesign. And I feel like I'm doing this at the practice, and I do it for clients. But I feel like I would expect the NHS to grab this and say, we need to transform the way we do primary care. And here are some templates and some organizational structures. And here's some examples of how better recall could be delivered. And I think that's missing. And if we did that, a lot of the subsequent issues would become easier to manage or resolve. Yeah. And I think the example I've given is kind of proof of that.
I'm just anticipating something. There might be people listening, people in the comments, actually thinking, you know what? You've given some inspiration there about actually this is a problem that we're facing in our practice. What I can probably speak on your behalf here, is that you're probably more than happy to be contacted to have these discussions in a more meaningful way, or actually apply these two practice problems directly, isn't it? Because that's what happens.
I share this insight for free, right?
Yeah.
So I give talks at conferences all the time where I'll say, look, this is the way I am addressing lipid therapy.
Yeah.
This is the way my practice has done it. And this is the way a lot of practices do it. And I would recommend you consider this person analyzing the result. I would recommend you send a message for this cohort and blah, blah, blah. And if you did it this way, this is how much money you would save. This is how many appointments you would save. And this is how much income you might generate actually as a result of hitting this QOF target that you're struggling to achieve. So I do quite a lot of this anyway. But obviously that's fine, but a lot of practices need it tailoring. And that's why I use the word clients, right? Because sometimes practices will say, well, can you advise us and can you work with us to redefine our thing? And I can. And although I'm happy to make a business out of this and I'm happy to get paid, I think this is a fundamental NHS issue that I would hope the NHS wants to address. And I think addressing it on a more national or at least regional level should be the priority. And then when you have capacity in the system, then people probably will have the headspace to talk about prevention and preemptive conditions and all the rest of it. Because I wasn't having this conversation when we were doing single disease reviews. Do you see what I mean? I've now got headspace to have this conversation. We've now started getting involved in research projects, which we weren't doing when we were struggling to meet demand. So once you free up capacity and you deliver a better service, the practices start to get involved in more things. And all of that is going to lead to patient improvement.